Thank you for that. Governor Lynch, and then we'll...
The question that you asked, I think, is a fundamental one that we need to discuss. And the question is, can you stabilize costs or lower costs and not affect quality? And I would contend that we can do that. I think technology is an important aspect, an important element of how we deal with the cost in order to make us more efficient. Technology should be able to do for healthcare what it has done for virtually every other industry in the private sector. It ought to be able to improve quality, improve customer service, and stabilize costs. And that means providers being able to prescribe medication electronically and evolving toward electronic medical records. Transparency is something that was discussed yesterday. We need to continue to push transparency in all that we do, not only around cost, but also around outcome. In New Hampshire, we're piloting medical homes, similar to accountable care organizations that, again, were discussed yesterday, evolving away from fee-for-service and more toward total care of the patient. And obviously, stronger focus on prevention and wellness. In New Hampshire, my wife, Susan, who's a doctor, she specializes in pediatric cholesterol management, initiated a program years ago called Walk New Hampshire, getting school kids to walk a distance over time equal to the length of New Hampshire, 190 miles. You know, Governor Plenty talked about a number of initiatives in Minnesota that I think are very important ones. But I think it's an important issue that we need to see if there's a consensus as to whether or not we can stabilize costs or lower costs and still not only keep quality high but improve quality.
Maria, let me offer a couple of thoughts on some of the issues my colleagues have mentioned. We have to, I think, reform how we deliver care. It's not just about money, and if we make the kinds of reforms that we've discussed this morning, we can indeed get a handle on those costs. The medical home concept that Governor Lynch mentioned is something we're doing in Vermont and other states are. I was pleased that Secretary Sebelius announced that Medicare very shortly will begin some pilot programs to participate in that strategy, because we have to have all the payers, public and private, at the table. And that leads to another important element of what we need to do, and that is change the way we pay for care. Now it's volume driven. We pay for procedures and tests and drugs and admissions. We pay for stuff. We don't pay for outcomes. We don't pay for the quality of that care. And we have to align that, I think, if we're going to make progress on quality improvement and cost containment. So what we do in Vermont is pay an incremental amount to our medical home primary care practices on a per patient per month basis if they adhere to certain national quality standards. And that's the kind of incentive that works. It can be significant in a practice with several thousand patients. So if we align our payment with the outcomes we want, I think we can get a handle on the cost of medical care in our country.
Paying for outcomes and only or mostly, and not for that volume that we're doing right now. We're going to go to Governor Perdue, and then I'm coming back to you, Governor Manchin.
Thank you. We pay for outcomes in North Carolina, too. We are one of the initial states that began the medical home. But in our fourth or fifth iteration, and we've just gotten one of the 646 waivers in North Carolina to provide the managed, if you will, Medicare care. We believe that a medical home has to be much more comprehensive than just a primary care provider, although that's the onus of care. That's where you start. But then we have a network of community care providers, Maria, anchored with a case manager, so that if I'm a Medicaid recipient, I don't necessarily go to the doc initially. I use my case manager to put me in a wellness program to help manage my asthma or my diabetes. We are not only bringing down the cost of care in North Carolina for our Medicaid population, and I believe for soon to be our Medicare, we are actually trying to make sure the services that our patients receive are the services they need, and then front load the system with a complete community-based wellness initiative so that folks do realize it's how they manage their disease. I don't believe you can just provide a medical home with the doc. I've never believed that. I think you've got to have that comprehensive array of services from the moment of entry into the system as you navigate through different levels of acuity and care to the ultimate outcome for us, which is a cheaper benefit with a healthier citizen.
Maria, the greatest savings that I believe that all of us could prosper by is the technology, and Governor Lynch just mentioned that. We have telecare, health information technology, but the exchange of this technology, the administration, the Obama administration, predicts that there could be as much as 30% savings. 30% savings by this type of technology and exchange in my little state would be $3 billion of health care savings. That means $1 billion of savings just in my Medicaid program.
How is it saving so much money? Well,
basically
exactly
what you have is that unnecessary tests and prescriptions, the redundancies, the mistakes, the lawsuits, it just keeps piling on. These are things that we could all have tremendous savings immediately from. We seem to be bogged down in debate how we're going to deliver it and who's going to be the winners and the losers. But we all win on this one, Democrats and Republicans.
Governor Ritter.
Thank you. We adopted a sort of a way of going about this called building blocks to reform. We had a commission that said the least expensive statewide plan we could implement would cost us $1.2 billion. And people in Colorado think the system's broken. We're not going to put another $1.2 billion into a system that was broken. So we've gone about it in a step-by-step fashion. What's interesting as part of this conversation is almost everything that's been mentioned we are working on. We have an initiative on, and there seems to be a great deal of consensus among states about the things that are necessary. We have a technology initiative. We have a transparency. We have a hospital report card. We have medical homes for children. We have both delivery and payment reform that we're working on. We did tort reform in 1988 before it was cool. We put in place caps on non-economic damages, and on economic damages we've only changed it once since. So it's not, tort reform is not the big enemy in Colorado, and yet we are the 7th most expensive state for health care. And so with all of these, we have an initiative currently looking at the value of care, and I think I agree with what Governor Rendell said at first about this relationship between cost and value. There really is the quality of care, that you can improve the quality of care and actually reduce the cost in doing that, and we really need to focus on that. But one of the big cost drivers for us has been uncompensated care. Our inner city hospital did $375 million in unreimbursed care last year, the Denver health system. So what we did was pass a thing called the Health Care Affordability Act. The more you treat Medicaid patients, we put in place it's called a fee. Every patient bed, there's a fee, a provider fee that's paid in. The federal government matches what goes into that. And so if you are providing care for unreimbursed care, then you're going to get additional money. And if you're not, you're going to be paying into that fee. And we're going to cover 100,000 people with doing that. So the last thing I would say is, with all of this sort of consensus, that there does seem to be about these things that would drive down cost and also help us focus on quality care, we have to be able to get to some common ground that they've been unable to get to here in Washington, D.C. Right. That's just, it strikes me that this is something we can't fail as a country. If we fail to do it, I mean, we're in really big trouble, because the amount we'll spend on our GDP just makes us not competitive, and yet we have things that we, I think, can come to some common ground on, and that may be what's necessary to form the basis for a bipartisan solution to health care.
Yeah, I mean, we face these dilemmas, and it's going on in other industries as well, whereas we want the services that are so important to our people to be low in cost. We want them to be available. We want everyone to have access. And it's the same as banking, plain vanilla banking and our deposit money. And yet, many of the companies that are in leadership positions in these areas are looking at shareholders, facing a different constituency in terms of making sure they have revenue growth, profitability, and yet from the other side of things, we need their services to be there for the people. So we are really in a very, very interesting time right now, and it's creating amazing dilemmas. Yes, Governor.
Well, yesterday, Maria, we heard from a couple of wonderful physicians and authors that I think answer your question about can we increase quality and reduce costs.